Good afternoon, everybody. We're going to start the final session of presentations and papers today. We're going to start first with Tim Davis, who's going to talk about comparing treatments in clinical studies. Welcome, Tim.
Okay, thank you. I'm a jobbing hand surgeon who enjoys doing a bit of research. And this is partly a cautionary tale to warn you what you get into if you get obsessed with clinical research, and also some personal views which you might totally disagree with, which is fine. I am pressing the button.
Can we advance the slide?
Throughout my career, I've always had a research yearning to complete a multi-center, fully funded, randomized clinical trial. The main reason for this was to prove to the UK hand surgeons that we can compete for funding with oncologists and cardiologists, and also to see how they work from the inside. And the study I'd planned to do this on was on Dupuytren's contracture, comparing limited fasciectomy with dermofasciectomy for proximal interphalangeal joint disease. And I'd spent a while writing a protocol, and I produced a draft protocol and then submitted it to a clinical trials unit in Nottingham, which is designed to convert research ideas into funded research projects in 2009. And I was very proud of this protocol. It was taken a lot of time, and it covered everything, and it was really good. So I went to this meeting with the clinical trials unit in 2009, and it started quite well with me explaining what Dupuytren's was, and then went downhill fast. They kept asking whether there was a systematic review. They were particularly interested in how I'd done my PAR calculation. I was particularly interested in not telling them how I'd done it. They asked about recruitment rates and how many patients would need to be seen and how many centers are well. And it went on, and I felt like a rabbit caught in the headlights of a car. I was stunned and really out of my depth. And it went on for 90 minutes, and at the end, they said, well, you can do some homework, do a systematic review. As unbelievably, in 2009, there wasn't one. Find data on likelihood of, on how likely you are to collect patients at what rate, and then, and only then, come back. And I was uncertain whether to come back. But anyway, I did my homework. We did a systematic review, which had the usual conclusion, and the study was taken on by the clinical trials unit. And the study team was formed of research experts in their fields, trialists, statisticians, an academic general surgeon, and patients. And we submitted this to the National Institute of Health Research in May 2011, 2 years after I'd got started. And it was an enormous effort. And it was like writing, the grant application was like writing in a foreign language, which I assure you is incredibly difficult if you're English. But I was helped enormously by the research team. And we put in this bid for 2 million with those primary outcomes. And then we had to sit and wait for months till the letter came through, or email, saying what the outcome was, which was rejected. And it really was, after all that effort, like having been stabbed in the heart. like that. So we had a post-mortem, not of me, but of the study. And we realized that the reviewers were not convinced we could recruit and retain successfully to the study. It was too expensive because there was too much face-to-face follow-up, and we were using the wrong outcome measure, which was a recurrence, which is an angle and not a measurement of hand function, which is what we're trying to treat. We changed slightly what we were going to study to needle fasciotomy versus limited fasciectomy with an economic analysis. And then to cut a long story short, we did a feasibility study to prove a fully blown multi-center study could be done, proving that patients would be recruited and be happy to be randomized to either treatment and undergo either treatment, and that we had a suitable outcome measure and could calculate the power of the study. And that, at a cost of $250,000, showed that we could do a multi-center study. It was feasible. And then in 2019, we applied for the study funding for the multi-center study, HAND2 called, and we got that in 2019, 10 years on since I started off. And that's continuing and hasn't finished. So what have I learned on the way about this? And one is the different views and attitudes of what's needed by researchers and clinicians. Researchers just want a single answer to a single all-encompassing question. Basically, they want an overall outcome measure, which is a PROM, and they're not keen on doing subgroup analyses on the study. They just want to do the analysis on the whole group. So they're not keen on splitting up MCP joint affected alone versus proximal interphalangeal joint alone. Clinicians want answers to multiple questions, some of which require complex objective outcome measures, such as measurement for recurrence, finger stiffness, nerve damage, and also reoperation. But if you want funding, in the UK at least, for a high-quality randomized RCT, you need to play according to the researchers' rules and have a PROM as your primary outcome measure. And I actually agree that is right, because it measures function. But you can slip in a few secondary outcomes, they'll allow that, and a few subgroup analyses, they'll allow that when they've got to know you, which will make the study more interesting to surgeons and show what the problems are, so that if you're trying to improve a treatment, you know what to address. The other thing is that the researchers and funders prefer distant, not face-to-face follow-up. So they like PROMs and questionnaires on which to do health economics, as this reduces the costs, though the costs are still high. Clinicians will want to know if the finger's bending up again, and that's difficult if you're not allowed face-to-face follow-up. You need a method of which patients in their home can assess finger straightness. Now, goniometry, if you're not used to it, is very difficult, and even if I still find it difficult, and I can't do it on myself accurately. Photography, well, yes, you can have a smartphone, but even then it's quite difficult to do it on your own and get the absolute right plane on which the photograph should be sent. So I'd been thinking about this since I was told I needed to by the Clinical Trials Unit in 2009, and my aim had been to try and find an accurate, simple method which a patient could do on their own at home. And then I apologize, when I put in I had no conflict of interest, I'd forgotten about what's coming next. So don't look away if you're upset. But I would ask you the following of angles. Which of these two hands, actually the same hand, do you think will have the worst function? The one where it's completely bent up or at 90 degrees? My view is it depends on what you're trying to do. Both these hands have 90-degree contractures, if you measure the total contracture. Which hand do you think has the worst function? And I think the one on the right probably has the worst function. And this led me to think that we're all measuring angles, but is the vertical height of the tip of the affected finger above the palm better at predicting functional impact? And is this something patients could measure on their own? And I dreamt up this device, which we used in HAND2, which can be done by the patient alone. And now can we start the video? I don't think I'm going to be able to. Can you click on it, please? You hold the device in one hand, put this device on the other, put it flat on the palm, as shown there, then loosen up your fingers and straighten them. And in this one, we're measuring the ring finger, and you can see the tip is at number 5, which means it's 5 centimeters above the palm of the hand. And it's a black 5, showing the contractures less than 90 degrees. And then you do it again to check it's working. And again, it's about the same. And you can also measure flexion deficit, which does sometimes occur, occurs following surgery. And here is a red 3 there. So that's what we used in the study. It works well with a lot of patients, but some find it difficult, despite instruction manuals and videos. Like everything, it's not always perfect. So what about outcome measures? I've thought a lot about this, and you can disagree with me, but I think recurrence is a terrible outcome measure because it's only as bad as the treatment it requires, if any. It's usually an angular measurement, but if you're in an RCT, it's difficult because it's only going to have to be measured. It's going to be measured by study participants or the hospital research team. And each hospital in the UK has a research team, and they're almost always nurses, not therapists, who've never seen a goniometer before, but are very good at taking blood, as most of the research is on blood tests. So that's going to be difficult, and you're going to be cautious about the reliability of your measurements of angles done there. And the other thing is, does recurrence mean worsened function? And it doesn't really correlate well with functional loss, as far as I'm seeing. And that's one of the reasons for that is that that would be considered an excellent outcome. That's at 5-year follow-up. And that's, if that was your primary outcome, everything would look good, and it would completely ignore the fact that that's as far as the fingers flex. And that would be just put as a complication further down the study, and nobody would read it because they only read the abstract. You could think of reoperation as a good outcome measure if it's done for recurrence. But do all recurrences need treatment? And more specifically, does everybody with a recurrence want a revision treatment? Now, Jeremy Rodriguez was in Nottingham at the time, and he did a follow-up of limited fasciectomy patients at about 2 to 3 years, I recall, and visited them in their homes. And they'd mainly undergone limited fasciectomy, and he found quite a few, a significant number, had bad recurrences, but didn't want to go through it again. And I think that's something we mustn't forget, that not everybody wants another limited fasciectomy or whatever. It's different for a needle fasciotomy. So what about PROMs, which I think are the best? Well, you could use the Eurama Dash. Both are mainly functional. But what is tending to be used in the UK, is the patient evaluation measure, which is a symptom assessment, not on what you can do. I think it's still totally unvalidated, but we all like it. And we compared these in the feasibility study we did, and found that all responded well to treatment. You could see all of them improving with the treatment, but the patients didn't think the DASH and URAM were as good, as relevant to what they were feeling, and didn't allow them to describe their feelings as well as the PEM. And that was mainly in the limited fasciectomy group. On the right, you'll see patients' view of relevance of the PROM in the needle fasciectomy group at 0, 2, 6, and 26 weeks. And again, the limited fasciectomy. And you'll see at 2 weeks, the patients with limited fasciectomy did not think they could describe with the URAM how they felt about their finger. Whereas with the PEM, which measured symptoms rather than function, they could. So how should you assess the outcome of Dupuytren's contracture? In my view, you need 3 things. You need the patient's assessment of function as a long-term, 5 years plus follow-up. Now, unfortunately, in the UK, you're not going to get funding for a 5-year follow-up study in the first instance. You have to do a 2-year follow-up at the most initially, and prove that you've recruited to that satisfactorily and retained at least 80% of your participants by 2 years before you're going to get that. And even then, you may not. You also need to record somehow the patient experience, what it took to get where they are after the final outcome at 5 years. And that can be a PROM. Basically, we used a 1-question PROM, the same weekly in the first few weeks to see how they were recovering from their surgery. And then the cost to the health purchaser of getting the patient to their improved level of function and maintaining it, or as best possible, for the next 5 years, which will mean the costs of reoperations and other interventions. So, what about funded multi-centre RCTs? What do I think about them? I think they're very good for studies with obvious, universally agreed primary outcomes, such as death. You can't feign death. Weight loss or a blood test. They're really good because there's a whole team behind you collecting data and maintaining it and chasing lost data. And they're also good at maintaining participant follow-up and chasing participants as much as possible and avoiding bias during the analysis. And for heaven's sake, they really ease the burden on the research on the clinicians at the recruiting centres. But in my view, they're ridiculously expensive. I mean, this whole lot has cost about £2 million. And it's incredibly difficult and time-consuming to prepare the funding application. So think of that before you start off. I didn't. The intervention variability, it can't get over with surgery. It's not like taking a tablet. One surgeon's limited fasciectomy and needle fasciotomies may not be as good as another's, and that may affect it. But this is a pragmatic study saying what is the likely overall outcome in the NHS health service. And they're not good for complex outcome measures, such as measuring angles or measuring sensation. Now look, this has taken me 16 years so far, and we still haven't finished the RCT I set out to do in 2009. It's a rocky road, and if you've got a busy clinical practice, it's time-consuming. But would I do it again if younger? Yes. Overall, I found it really interesting, but at times, not so good. But if you're considering going down this path, be prepared for setbacks, many of them which you won't have predicted. Except it may take longer than you think, but I don't think it will take so long now because there's much more data out there about Dupuytren's disease. And for heaven's sake, remember you're part of a team, you're not the boss. They know far more about running research than you. Listen to them and think about what they say. Thank you.
Any questions for Tim Davis? Besides that, not any of us are willing to go down that 16-year road.
Yeah.
Tim, where can we get that device for self-measurement?
You can't, because it may not look at it, but it's thought to be a dangerous instrument, and it needs CE approval, even though it's just a ruler. So basically, though it has to be fair, I went through customs at St Pancras, and I had to be searched because I set the alarm off because I got a hip replacement. And the person examining me found this and looked at it most suspiciously, but he let it through. But no, you can't at the moment. We're only allowed to use it in this study, and it hasn't been validated how reproducible it is yet. But I think it might work.
Dominic?
Tim, when can we expect the results?
Now, that's a good question. I can tell you the 2 years will be... well, we finished the study and it's supposed to have written up by September 2027, which is 18 years afterwards. And then we're thinking about a 5-year follow-up. But I think I am going to bow out on that one.
Your grandchildren will finish the study.
Yeah, my family have views on that.
Yes.
Thank you for the wonderful talk. My question is that are we making it overly complex, the outcomes? Because like we were measuring many things, and in all the outcomes except for the quality health, like generic health quality, we saw the same result. And then sometimes when we are testing surgery against no surgery, we don't find any effect in any of the outcomes. I know we have to choose one primary outcome, but still, like we have to, once you ask the global improvement, you look at the angle, you look at the function. So I think you get an overall picture, what's the effect. And I think sometimes we're just making it very complex when we are designing this.
I agree, and the more you ask patients in a questionnaire, the less likely they are to complete it. They'll give up halfway or not even start it, which is difficult. The problem is, do hand surgeons generally, are they prepared to change their practice on the result of a prom? And I think you've got to make it more interesting for them so that they actually read it and consider it. I mean, I want to know what is the incidence of nerve damage after needle fasciotomy for a PIP joint release. Is it worse than after a limited fasciectomy? And things like that. And I want to know if Dupuytren's is creeping back up again. So it's difficult, and I think you can overdo it. And if I had my time again, I wouldn't have as many outcome questions as I asked in this one.
I'd like to ask. I agree with the Finnish colleague that it may be completely out of all proportions. You said it costs you 2 million in 16 years of your life. All you have to do is ask the patient, are we any good or not? They'll tell you. Now, I'm a radiotherapist, and I've got the photographs of the palpable disease at presentation. And then the first thing I say when they come after 6 months, after the treatment's been complete with radiation I'm talking about, how have we done? Either they say, doctor, it's great, or it's not. That's all you want to know. So they're to help the patient.
The trouble is, I mean, part of the reason for doing this is to tell health providers what the outcomes are of various treatments, so they don't start saying everybody's got to have a needle fasciotomy because it's so cheap in the short term, because it may actually cost more in the long term. And they're not going to just take your word for it. You're going to have to do something harder than that to prove the value and the health economic value as well.
Since 2010, I've been working with NICE, and they've now agreed that radiotherapy can be used for early Dupuytren's disease. They pay for it in the NHS. The only thing in Britain, there are not enough people who are doing it.
No, I know. I mean, we toyed with doing an RCT of radiotherapy for early disease, but the problem with it is getting hold of patients with early disease, and also, which we don't have at the moment. And we first felt, because we am only in secondary care.
Well, that's interesting. I get lots of early disease, and a very good idea is invite the press to come and assess your work.
Well, why not do an RCT?
I
Prove
think,
it.
sorry, sirs, we have to continue.